Hi, good evening. You got a minute? Let's go through some numbers. We're going to go through the dashboards tonight, but then we're also going to talk about infectivity. We've been focused on admissions because that's what we were worried about. The more hospital admissions we got, when they started rising rapidly, concerned about overriding our ICUs. We're going to continue to watch that number because it's some of our best indicators, because it doesn't vary by the number of tests or who's getting tests. So we're going to continue to watch that. But as we start focusing more and more about how we open up schools and when we can open up schools, and can we go from 25% to 50% to 70% occupancy in things like restaurants, what do we look at? Hospitalizations, sure, but we also look at infectivity. We're also going to be taking a look more and more about how many people in our community are infected. So when you go into a restaurant, what is the size of the group, and what are the chances that somebody in that group is going to be positive? May not know it, may be asymptomatic, but still contagious. Let's start taking a look at infectivity. So tonight, a lot of that is going to be looking at infectivity. And I have Jaeson Fournier with me here from CommUnityCare. So we're also going to do an in-depth dive with respect to our Latino Hispanic community, both with respect to infectivity and otherwise within the patient universe that is community care. All right, so let's begin. The first dashboard is the city dashboard. We always take a look at admissions first. The number back down to 30. The 7-day running average is 27. As we talked about yesterday, you have to go back to mid-June to get to a number that's as low as that 27. So it's been a while, but we've gotten back down to that number. But as you can see from that chart in the middle, we jumped from 27 up to the red area in about 2 weeks. So it doesn't take long when things start going south for it to start going south quickly. But that's a good number. You can see the chart in the middle where we graph those things in kind of a cartoonish kind of way, that it's still going down, but it's leveling off. It's kind of a plateau. We need to actually push it down even further so that we reduce the infectivity in our community, so that we start having more freedom and flexibility to try stuff. Number of new cases, 291. I think that number is still artificially high, still in part a function of the fact that the state dumped 2,000 cases on us this weekend from their reporting, some of them going back all the way to April, some of them being duplicates, taking us a while to be able to go through those to actually correct the data so that we can rely on it. The numbers in the middle are the mint-colored numbers. That's the 7-day running average for hospitalizations. You can see that it's 227, 7-day average. Number in our hospitals tonight, 208. So we're beating the 7-day average, so we're continuing to head down. ICUs, 82 is the 7-day running average. We have 73 in our ICUs, also then heading down, 55. 7-day average on ventilators, 50 people in our hospitals tonight on ventilators. So again, tonight beats the 7-day running average, which means we continue to head down. Doubling time is every 83 days. Remember, we used to be at a place where we were doubling the number of new cases every 15 or 17 days. So good job for the city generally, but that plateau, we still have to drive it down. Let's go to the next dashboard off the city site. You can see we crossed 25,000 new cases yesterday. The 208, 7350 are the daily numbers we just talked about. Deaths, 346. That's the same number we had yesterday. But remember, yesterday's number was 9 up from the day before. Still a very deadly disease, as we talked about yesterday. With those additional 9 deaths, COVID became the fourth killer of people in our city, passing now strokes, more deadly than strokes. I also pointed out for people that say the flu is also deadly, the flu ranks 13th, and there were less than 100 people that died from the flu in our last season of flu. All right, so let me bring in Jaeson Fournier, who can be with us here. And I want to go over some citywide numbers first, Jaeson, before we get into community care. But just so that people know who it is that's with us on the screen. What do you do, Jaeson? Tell us where you work.
Yeah, sure, Mayor Adler. Very happy to be with you this evening. So I'm Jaeson Fournier. I'm the Chief Executive Officer and President for Community Care Health Centers, which is a very large safety net primary care provider in Austin and Travis County. And we partner very closely with Central Health, the hospital district or healthcare district in the area, to make sure folks who are uninsured or underinsured have access to the care they need and deserve, sir.
And one of the big reasons that we created Central Health and created that whole system was to be able to make sure that medical care got to everybody in our community, including the people that historically have not had the same kind of access. We've talked about that a lot in the evenings with respect to people that are most susceptible to this virus, in part because of generations of lack of access to health care and healthy foods and the like, and leading to comorbidities. That's the population of the community that you're most focused on helping.
That is correct, sir. Yeah, our mission at Community Care is strengthening the health and well-being of the communities we serve. And really, when we take a look at the crux of that and the core of it, it's really about achieving health equity for our neighbors and friends here in Austin and Travis County. It's really about making sure that we level the playing field so folks can gain access to the medications they need, the clinicians they need. But it extends beyond that, making sure that they're connecting in with resources that they might not otherwise be able to tap into. And it, of course, all starts with the healthcare that we're providing directly, but then the various different relationships that extend well beyond the four walls in the exam room to try to help folks live longer and live better. And so privileged to be supporting folks in this endeavor locally here. And, you know, having come to Austin a little bit over 3 years ago, I've been unbelievably impressed with the commitment locally to make sure that everyone has access to care. There's still a lot of work ahead of us, and we'll see that in some of the data we take a look at this evening. But certainly we're doing better than most communities for sure.
And that's good. Still have a long ways to go. And as people know that have been, joining me here in the evenings, we have some pretty disparate impacts in our community, with over half the people that are getting cases, new admissions, part of the Latino community in our city. The death rate higher among African Americans in our community than the white population. So thanks for that focus. We don't do well as a community unless every part of our community is doing well. But let's take a look at the whole community for just a second. These charts are not yours. These charts are from Austin Public Health. And I'm going to use those, Jaeson, to kind of introduce the conversation about infectivity in the city. And I know those are small numbers, but maybe you can see them. This shows what the percent positive is among the people that got tested in our city. This is not an exact number because we don't know for sure everybody that was giving a test, although we're supposed to, because they're supposed to be reported into the state. I don't think we actually get all of that data. We get a lot of it. Dr. Escott and Austin Public Health, Director Hayden, have worked really hard to try to get everybody that's doing that testing, and that's hospitals, but it's also labs, and it's try to get everybody in a room, at least the big players, to make sure that they're sharing data in a regular way so they can be counted. So this kind of numbers haven't been available to us until very recently, and we're getting better at these numbers. And I think Dr. Escott's going to be presenting some of these numbers on the dashboard coming up, hopefully by the end of the week, if not then early next week. But across the bottom is the number of weeks. It begins back in March. We're now on the right side. That's week 32. Week 32 is actually a week ago. So that's a trailing number. But you can see as we go through these different weeks, you can see that when we were seeing that spike in June, that overall in the city, we got to the place that over 20% of the people being tested had the virus and were coming up positive. We've continued to give out a lot of tests in the community. You know, in May we gave 40,000 tests. The goal was 10,000. In June we gave out 51,000 tests. I think the goal was 40,000. In July, the goal was 60,000, and we administered 70,000 tests. So we're giving more tests as the number of weeks continue to go. You can see the infectivity percent number that we're seeing. The reason this number is not as reliable in a lot of ways as the admissions number is because this number will vary based on the number of tests you give and who you're giving the test to. But overall in the community, you can see we were up at over 20%. The test in week 32, which was a week ago, down to 9%. Dr. Escott is talking about keying that color chart that says, you know, when you can open more and more things and when schools could go to a higher and higher population. One of the factors he's going to take a look at is what is the percentage of infectivity in the community. But you can see how we're doing a better job as the infectivity percentage is coming down. We isolated more. People are wearing masks. It's not passing as much as it did before. So this, Jason, is good news as we see this number.
Very much so. It's very positive news, and I think it speaks to the efforts for us community-wide. People embracing the protective measures that are being recommended by yourself, Dr. Escott, other stakeholders within the community, and really looking at how they protect themselves, protect their loved ones, donning a mask, social distancing, all of the things that we can do, making sure that we're using hand sanitizer. All of those things I think are contributory. And I think the important part is, as we've made some progress here and we're seeing a very positive downward trend, is for us not to let our guard down. It's really about going ahead and maintaining the initiatives that have gotten us to this point in order for us to be able to still have our kids be able to go to school, attend to businesses, and to do the things we all want to do. It's extremely important. But definitely a development. And when we look at the CommUnityCare data in just a little bit, our data is showing a similar downward trend as well, which is very positive because in mid-June and early July, we were seeing positivity rates closer to 40% for all of the tests that we were providing. And then coupled to that in our Latino Hispanic population, it got as high as almost 48% 1 week in July in terms of the tests that returned. And to date, CommUnityCare through earlier today had provided close to 26,000 unique tests across the community, with many of those directed towards individuals who are uninsured. Actually, about 80% of those tests have been provided to individuals who are uninsured. And they're not just to our patients. There are 60% of those 26,000 tests have been provided to community members at large from Austin and from outside Austin as well, but the vast majority Austin and Travis County, of course, sir.
Okay. And we'll get to those numbers here in just a second. That would be the universe of patients that you have, but really helpful observations. But these numbers are citywide, right? So it's everybody. And these are that aggregated numbers. And when you look at an aggregated number, it doesn't tell you the whole story, especially on something like this virus, where we know that we have communities that are more at risk and suffering disparate numbers. So Nina, why don't you pull up that second chart that Dr. Escott gave us? Again, looking at the citywide numbers, and this is a harder chart to see. The numbers get a little bit smaller, but the top group of the 5 color bars is week 33, and then the next 5 color bars going from the top is week 32, week 31, and the bars down at the bottom are week 30. You saw what the overall numbers were citywide, but this is that those numbers broken out by race and ethnicity. The green number that you see at the top is the infectivity rate among the Asian population, Asian background. The blue line is Black or African American population. The line that extends out to the right, that's kind of the gold line, is the Hispanic or Latino population. That's infectivity, number of percentage of positive tests among tests given. Below that, the gray line is other, and below that is the kind of black line, and that is white. So when you look at this, you can come to lots of different kinds of conclusions looking at this number. One of them is it shows that as we go from the bottom in week 30 up to week 33, that overall the infectivity in our city is going down. That's what you saw with those aggregated numbers. You could also see that by population, the number has gone down most significantly in the Hispanic or Latino population, and that's been steady progress over the last 4 weeks. But then that's the population that's had the most ground to be able to try to make up. Even though they've gone down, you can see that the disparate impact is still greatest among that population. You can see that the African American population also trending downwards, but over the last couple of weeks has flattened out, and that's a concern to us and something that we're watching within that population. But those are the citywide numbers. I just wanted you to see that at this point, the infectivity rate among the Hispanic population is somewhere in that 12 to 14% range citywide. Among the Black African American population, just under 6. The white population is just under 4. Now, the goal is to get everybody down collectively, but it also means not everybody, not just collectively, but each one of the groups, each one of the cohorts in our community. We have to work real hard to get down. Any observations about this, Jason, before I go to the charts that you brought?
Yeah, Mayor, I think the observation is this is tremendous progress as a community. And again, to reiterate, a lot of this is due to our collective efforts, right? And so I think we still see disparate outcomes, and it means that we've got work ahead and we need to increase awareness. But I think when you take a look at this, it's really folks embracing the masking. It's embracing the fact that we need to go ahead and pay attention to our environment and as best we can make sure we're social distancing and really looking at gatherings. I know we've been engaged with our colleagues at Austin Public Health and at Central Health about pushing out information specifically to the communities that we serve to go ahead and make sure that there's that increased awareness. And so with our partners at Central Health, did a lot of mail drops to high positivity zip codes to increase awareness and education. And we've also engaged in contact tracing. And one of the things that we've learned through that process, through a partnership with Austin Public Health and functioning essentially as an arm of public health here in Austin for the contact tracing we're doing for our patients, is that our brothers and sisters in the community aren't recognizing that if even when they've tested positive and they know they have an infection, a lot of folks feel that if I'm not that ill, then I can't be infecting individuals. And I think it's important for us all to recognize that as soon as you've tested positive, this thing is highly virulent. And we need to make sure that even if you feel this isn't the flu where you feel relatively okay and you can go about your normal business, because the risk here is you're going to spread it to others and to your loved ones as well. So we need to take those precautions, especially when you've tested positive.
Okay. Well, let's go ahead and let's take a look at the numbers on the charts that you brought with us. I want you to tell the people that are watching us what's shown on the charts that you brought.
Yeah, we'll do. So I think we first wanted to start just so that there was generalized awareness of the community and to provide some perspective to the community members that are joining us this evening as it relates to who does community care usually serve, right? And so in calendar year 2019, community care served 116,175 unique individuals, a very diverse patient population. About 67% of our overall population is Hispanic Latino. For those that reported, and there was about 94,000 or so folks who reported their ethnicity. From a racial perspective, about 18.5% of our overall patients self-report as white non-Latino. About 11.5% or so are reporting as African American and then about 2.5% are reporting as Asian. So very diverse population. About 34 to 35% of the 116,000 folks we served last year in 2019 actually were best served in a language other than English. And so when we take a look at that, language barriers for the communities we serve and patient population is extremely important for us to recognize. And then when we look at from an income perspective, about 94% of the members of the community that we served last year had incomes at or below 200% of the federal poverty level. And that's actually who we're trying to reach the most within the community, are folks who are lower resource, lower income, and coupling that to uninsurance. And you can see by the graphic on the far right that about 56% of the 116,000 folks we served last year were actually medically uninsured. And when we look at our adult population, because we know the pediatric population is less at risk for an adverse outcome from coronavirus or SARS-CoV-2, that risk in our adults is higher because our adult population, which is a little bit less than 80,000 unique individuals served annually, is actually uninsured at a rate of 67%. So think about 56,000, 57,000 individuals coming through our doors annually who are uninsured. And so that in and of itself is a predictor for an adverse outcome. And the other part is a lot of our folks are working in the community as essential workers. And so they also are at higher risk because of the work that they provide to the community at large. So if we could advance to the next slide. So a couple of years ago, CommUnityCare did a deep dive into the community data and really trying to understand where needs were with our partners at Central Health and internally to guide where our care is. And one of the things that we identified were vulnerable population footprints. And really what we looked at were two factors. The number of individuals within a census tract, greater than 20% from a percentage perspective, 20% of the census tract living at or below the poverty level, coupled to a high school education level of less than 75%. And so we looked at those two factors and said, are they predictive of adverse health outcomes? And you can see by the map, it's a little tough to see here, but hopefully you can see the straight line kind of coming down the middle. That's I-35. And this is really aligned with work that the city's done through the city demographer and others, and concept of Eastern Crescent. Well, almost all the census tracts we identified that are vulnerable population footprint are eastward facing within Austin and Travis County, with the exception of North Austin around the Runberg area where it trickles over on the other side of I-35. Then what we did, if we can advance to the next slide, we took a look at, well, what are the outcomes? So if we looked at the Eastern Crescent, which is essentially the entire eastern side of Travis County, east of I-35, except for a couple of zip codes in the northern part of the county, and we compared that to the vulnerable population footprint, and then compared to census tracts that were west of I-35. And the information was quite dramatic. We're only showing a snapshot of this. There were many indicators. But what we realized very quickly is west and does not equal east within our community. And there's real reasons, as you've already alluded to, Mayor Adler, there's longstanding racial injustice and segregation that's occurred that has longstanding impacts on the communities and populations we serve, a systematic bias and racism as well, of course. And so when we take a look at that, there's a stark difference between health outcomes east and west within our community. So by way of example, that first bar, if you lived in one of the census tracts we identified as a vulnerable population footprint, again, that's individuals in that census tract, 20% or more in poverty, coupled to a high school education level of less than 75, you are 2.4 times more likely to have lost all your teeth by the time you're 65 compared to someone who lives west of I-35. And so we see that consistently when we look at, for some reason, the bottom part's not aligning perfectly on the graphic right now, the way that it's being shown. But for example, for diabetes, if you live in one of the vulnerable population footprints, census tracts are 1.8 times more likely to suffer from diabetes compared to someone who lives west of I-35. And so these differences really translate into the coronavirus pandemic in terms of who's potentially at higher risk within our community because of their social determinants of health, which sometimes are also political determinants, right? It's the choices that we collectively make as a group in the investments of resources, access to healthcare, for example, which our community has made a tremendous investment relative to the monies that flow to Central Health to support our services and the services of our brethren health centers here. If we can advance to the next slide. And so we took that into account in terms of as we stood up our coronavirus response initiative in mid-March, and as quickly as we could, really opened up testing, not just for our patients. We were actually, as you know, Mayor Adler, one of the first community-wide testing sites opened through our Hancock drive-through. And over time, what we've been able to do is provide almost 26,000 tests. That's thanks to the efforts of our care team members that are out there every day that are going ahead and making sure folks can access the testing they need. As I mentioned earlier, only about 40% of the tests we've conducted at that 26,000 have been directed towards our patients. The other have been community members. But one of the unique things we did with our testing is that we wanted to make it as low barrier, understanding how it might work best for our patients and the communities that we serve. And so we did a drive up on demand. Yes, there are wait times that sometimes happen, but when you don't speak English as your first language, or you're fearful that if you enter something into a computer, that it may be an obstacle for folks to access because they're concerned about immigration status, we reduce those barriers as much as possible. And that translated into folks seeking testing with us. What you're seeing, and it's tough to see here up at the top, similar to the graphics that you showed earlier, Mayor Adler, as it relates to the infectivity rate, what you're seeing there is a 5-week run rate on the top graphic on the left of overall positivity. Similarly, what we've seen is a nice drop in the last week. So for August 9th through the 15th, which would equate to your week 33, we actually saw our rate drop down to 17.8. The week before, it was sitting a little bit over 27% for those that we had tested. And again, this is just for the folks that we've tested, but you can see that it's been dropping steadily. In our Latino population, Hispanic population down at the bottom, we've also seen a similar drop, almost 10%. Went from 35% the preceding week to week 33, or August 9th through August 15th, down to 25%. But what that means to us and to us as a community and us at CommUnityCare is that we still have our work ahead of us, right? That means that we've still got transmission within communities that we serve and across the community at large, which means the mitigation measures that have been put into place and articulated so well by you and by Dr. Escott and Director Hayden and others, we really need to go ahead and make sure that those persist and we pay attention to it. And I really commend you and Dr. Escott for highlighting the infectivity rates, because I think, while the hospitalizations are extremely important for us to pay attention to, I think that the infectivity rates have the potential to go ahead and allow us also to know as a community how we're doing, and perhaps even more timely, especially considering now that turnaround times for tests have come down. At one point when we did 3,600 plus tests in a week, sir, our turnaround time pushed up to almost 10 days, which is inexcusable. It wasn't that we were able to control that. It's just the National Reference Lab that we were working with were overrun given what was going on. They've increased capacity, and now we're seeing that overall the turnaround times usually are within 48 to 72 hours. And then starting next week for our own patients through our clinics, we're going to be able to do point of care testing for antigen testing that will allow us to determine very quickly whether or not they test positive. They test positive, they're positive, and if it comes back negative, we'll have to perform a confirmatory test afterwards. If we can advance to the next slide.
Hang on, before you do, just go back to just a second. I just want to do again, just to make sure that people watching understand. Your overall positivity at the 17.8%, higher than what Dr. Escott was showing with his 9%. But the reason that yours is higher is because while Dr. Escott's is the population at large, your numbers are focused on the population that you serve, which itself has a higher propensity or a higher susceptibility or a higher vulnerability to the virus, because you're dealing with people that don't have the same advantages. They don't have insurance, and they've been dealing with generations of maltreatment. So your universe is not the overall population. It's a population that tends to be more vulnerable than the overall population. And that's why your percentages, both overall at the top, as well as your percentages for the Latino community, are higher, because you're dealing with that portion of the Latino community that is probably more inclined to not be insured and those kinds of things.
That is absolutely correct, sir, and well stated. And I think, some of the challenges that our communities and the patients that we serve really relates to, the ability to social distance, right? We're serving and have the privilege of serving folks who are multi-generational households. So coming through the door, you're not able to social distance potentially, and then there's higher rate of transmission that occurs. We also care for folks who are essential workers, be they healthcare workers, food industry, construction workers. And so, they've been, when things were really calming down with the stay-at-home orders, we actually saw that not happening in our population, because they were getting up and going to work, and they did not have the ability to stay home like so many others in the community, because their jobs required them to. And so I think the measures that we're putting into place and have put into place are helpful, but inherently based on what they do and the resources available to them, they are certainly at higher risk, sir.
That's why we've often referred to so many members of this population and community as our economic first responders, because they've been on the front line making the rest of our lives be able to function and move forward.
That is a great way to go ahead and describe our friends and neighbors who are supporting us so very well, and imagine how much more difficult this would be without what they're doing for us as a community. So if we go to the next slide then, and this is really just highlighting some of the trends here. What you'll see is that our overall positivity rate to date, going back to May 3rd, and you can see it really similar to what you were showing earlier, Mayor Adler, is the red line is our positivity rate in our Latino population. The yellow line is in our overall community, including Latinos. And then the blue line is the number of tests that we've conducted. So as we've seen the rates go down recently, we've also seen demand go down within the community, which also means that we have less folks who are symptomatic, which is indicative of less spread within the community. So I think this is all very positive news, but as we've mentioned earlier and I communicated, it's extremely important for us not to let our guard down and to make sure that we continue with the great work that we're doing. I think next slide, please. So I think, at the heart of what we're trying to accomplish through both our day-to-day clinical care services, Mayor Adler, in conjunction with you at the City of Austin, who are just tremendous partners, and as part of the coronavirus response, is really about achieving health equity. And when the way we look at that to overcome some of the longstanding systemic issues that have confronted the communities we've served, it's really about looking at resources. And so in collaboration with your team, at APH and with the city, we've looked at how best we position our testing sites. And so starting next week, we're actually opening up another testing site in Southeast Travis County that will serve a good chunk of the southeastern portion of Austin, including the Montopolis, Dove Springs community, but also accessible to folks in Della Valley and further east as well. And that'll be a site off Burlington Road. And we think that that site's going to be needed for the next 6 months plus. Hopefully we get to the place where we're able to transition that to a mass immunization clinic, but we're not quite there yet, as we all know.
Well, you guys are doing great work, and yes, there's a huge challenge. I'm so happy to see the progress, but again, we're all in this together. When there's virus in our community, among any part of our community, it increases the risk for the entire community. Which means we all have to get to the place that we all need to bring down the infectivity in all parts of the community for all of us to be able to have schools that stay open and get sustained, to have businesses that get open and sustained without us pinging back and forth and finding ourselves going from one spike to another spike to another spike. We have to keep it down and the infectivity down, and everyone has to wear their masks, social distance, wash your hands. Jaeson, please thank everybody at the staff at CommUnityCare. You guys are doing incredible work, reaching out to the community. You can see some of the results happening right now. Thank you for expanding the testing opportunities, for are getting equipment and information and knowledge out to the community as widely as you are. You're
I
really.
will certainly, well, sorry, sir.
Go ahead.
I'll certainly relay your thanks, but I also want to acknowledge that this is all about team, right? It's team across us, our friends and colleagues at Central Health, and really want to just commend APH and you, Mayor. I've talked with, prior to coming to community care, I've spent some time on the public health side years ago and have a lot of colleagues across the country. And when I talk with folks, the leadership locally here and the engagement with our hospital systems is just really been second to none. So, and I think that speaks well to our collegiality, our willing to do what's right for the community, but also Mayor speaks highly to your leadership as well as the county judge's leadership and others. So
thank you so much. Jaeson, thanks for coming over and joining us. Thank you.
Anytime, sir.
We're going to close out tonight by talking about Oliver, 7 years old, been pretty busy. Got a donated piano and is learning how to play a new instrument. He's learned several songs. He's attended his first recital, albeit virtually. He has not yet met his teacher, Mr. Treese, who apparently is doing an incredible job. Hoping someday to be able to meet in person. Now just doing the teacher virtually. Oliver is also doing nature trivia with Texas Land Conservancy, testing his knowledge of facts. His team, by the way, is called the Rangers. He wears his favorite Ranger hat filled with junior Ranger badges from all the national parks that Oliver has visited. He can't wait to go exploring again. It's a special treat. His family made a stock take pool for cooling off, watching backyard movies, including a late night movie of Jaws. I don't know how comfortable I would feel watching Jaws in the middle of the pool like that. I guess it'd be fairly safe. Still making me nervous a little bit. Oliver, thanks so much for sharing. You look cool. It's been hot. Everybody take care. Please keep pushing down the infectivity rate in our city. And y'all take care.